We always have appreciated the fact that the moral perspectives can differ, even amongst Catholics. And our moral perspective as the Hospital Association is that we are looking at a life that has a finite ending, and that there is appropriate use of these life-sustaining treatments, and then there's inappropriate use of these life-sustaining treatments. And we have nothing in this bill that confirms the right of a physician or a hospital to object through the religious beliefs that there is such a thing as inappropriate CPR. And so our largest objection is the fact that we have had no regard to the right to a conscientious objection.
Okay, very well. Thank you.
You're welcome.
Thank you, Chairman.
Mr. Chairman. Thank you. Senator Taylor.
Thank you for taking the time to be here and provide your testimony. And so, and you're a practicing Catholic?
Yes, I am.
Okay. And so, in that context, I mean, obviously, we've heard some testimony. You've been here for most of the testimony?
Yes, I have.
Okay. And so, what is your thoughts on a patient having a DNR put on them without their knowledge, without their family's knowledge?
We do not support having a unilateral DNR that does not include the patient or the patient's decision maker in the conversation.
Okay, so
we honor the right to have them fully informed to help make a good decision.
Sure. So just backing up, what I think I heard you say is, broadly speaking, you're opposed to a DNR surreptitiously being put on a patient without the patient's consent or the patient's consent, and if they're incapacitated, the patient's family.
I am opposed to the surreptitious DNRs, yes.
Okay.
The concern that we have is in the actual statement in the directive in this legislation that allows the physician to make that decision only in the presence of imminent death. Imminent death is not defined. Imminent death, if you ask physicians, is a series of clinical decisions that physicians will struggle with. We've already heard a lot about prognostic uncertainty. So we prepare for the arrival of death in such a way that we don't want to start a code and then have to stop a code because the physician wasn't there to declare imminent death.
Given your stated opposition to secret DNRs or DNRs without the patient's assent or without the patient, and if they're incapacitated, the patient's family, without informed consent, we'll leave it at that.
Okay.
So since you're against that, the spirit of this bill is to end that practice.
Yes.
Since you're against that, I mean, and I appreciate you saying you're against this bill, but the spirit of it seems to be consistent with your position of opposing DNRs without informed consent.
The spirit of the bill, as we have read this and reread this and have attempted to look at how can we help inform you about the religious beliefs that we do not subject people to CPR that has no medical benefit. That is a belief that comes from our respect for human dignity. So in this bill as it's laid out, certainly the patient has the right to make the decision and to have that declared. That decision maker who steps in as the family member, that surrogate decision, should be making decisions on the best interest.
Sure.
We're down now to that point where we have no directive. We have an unconscious patient who we do not know what is their preference, and we are now going to be making a decision. Are we going to hamper the right of a physician to determine appropriate levels of resuscitation prior to imminent death when we may actually harm a patient? So we really are focusing on that last piece about the only time a physician can have a DNR order written through the physician's lens of what's right for my patient is in the presence of imminent death.
Thank you very much. Appreciate you taking the time to be here. And thank you for your services to so many people here in Texas. Thank you, Mr. Chairman.
Thank you.
Mr. Chairman.
Senator.
So, first of all, I respect your position. I don't necessarily agree. I can't reconcile, honestly. Being people of faith on both sides, of different denominations but same faith, it's hard to reconcile some of the positions. That said, this bill does not prohibit a physician, if they're in their estimation, and I'm incapacitated with no advance directive, with no pre-planned authorization of what my wishes are, that physician, along with the concurrence of another physician, this would be unilateral in the sense that it was a medical decision only with no input because I'm incapacitated and there's no. That is still allowed, and it's within 24 hours. If death is within 24 hours, then that physician can make that call. But I don't want to get into the philosophical or theological discussions, but we're all dying at some point.
Yes, we are.
Every day we die a little bit less, or maybe a little bit more. And I know this is specific to those final days, but there's a lot of issues that it makes it hard for me to understand your position. But your statement that this is down to where physicians don't have any say when they believe it's in the best interest of the patient in that final day or two there, that we don't have anything telling us different what the wishes were. That's not true. The bill allows for that. I understand your concern that what is imminent death, or in 24 hours it's kind of in there. Well, if it takes 48 hours, nobody's going to, I think, look back and say, well, that physician may, because it starts with someone that didn't have the ability to relay their wishes. So back to Senator Taylor's question, philosophically and spiritually, the intent of the letter was, or the bill is, to give that voice. And if I give you my voice, then to have some other decision process override my voice is just something we probably would never agree on. But in the event that you just described, if I didn't have a voice, the doctors have a path to issue a DNR. So,
Senator Ferry, I would ask then that the language be improved, because there is no sense that the physician has that opportunity. You referenced 24 hours, prognostic uncertainty, and I'm certain physicians in this room understand that. We don't know, but we have the signs that can tell us when treatment becomes excessively burdensome, and there is no hope that we will reverse this process where a physician ought to be able to exercise this. And this bill has parts where we're uncertain on so many planes about, can a physician actually do this? We've talked about liability, we've talked about disclosures, we've talked about information, but we have not really clarified when can this physician really do this in his or her judgment, knowing that death is approaching, but hasn't met this nebulous, strange, imminent death which we cannot define. We know what it looks like, but can we really ever establish statutorily what we're going to call imminent death that will allow a physician to say, in my judgment, death is imminent and therefore a DNR is appropriate?
So therein lies the challenge.
Yes, it does.
Is it 22 and a half hours? Is it 22 days?
Well, I would like to hope that the state will defer to the judgment of a physician in that matter.
So then we basically have no opportunity for a physician not to, in their judgment, issue a DNR. It puts it back to where if I don't have a DNR file and I'm not speaking, I mean, you're going to give a physician to make that. I mean, that's the reason of the legislation. We want to bring some finite, consistent standards. We believe that there's probably hospitals that have great standards and policies, but they're not consistent depending on where you get brought into that day. So, but there's no magic formula for when, good Lord knows. He knew the day before I was born when I was going to die, and I can't change that. And if there's a doctor that has that wisdom, then I don't know if I'd want to be under his care to begin with. So we are trying to manage things that are not manageable. At the same time, I think having an active voice in that process, and then when I exercise that voice, that's the final word until God takes me home. But absent my ability to give you that voice, there has to be something statutorily that gives direction. And again, I don't think that 24 hours or 48 hours or 72 hours or 96 hours, I don't think there's a magic number there that gets us to where y'all would feel comfortable in that. I can tell you my personal experience in the hospice environment, they usually know within 3 days. They almost every case I've known, with the exception of my current situation, and even they did say it's going to be longer term, but I can tell you most hospice, when they were called in, my mother-in-law, they nailed it within 3 days. They knew. So there are ways to do that, and I don't think we're putting pressures on doctors to do any more or less if they feel pretty certain that it's going to happen. The 24 hours a gauge or a guide, but it's not absolute. So that said, I don't want to put Catholics against Catholics on here on the diocese. I would just ask if the senator wants that comparison. There's someone willing to do that, but I don't think it's a comparison of faith or issues. I think it's just a fundamental belief that dignity in life matters,
Yes, it does.
and we respect that. But it's God's call as to when that happens, and it's my personal relationship with Him that determines that. when I'm comfortable to say I'm ready to go on, not a physician or a hospital. I think that's the inherent discussion that we'll never agree on. I hope they educate me to make that decision. I embrace and encourage that discussion, but ultimately my wish, subject to the ultimate finality of when he decides, is what we've got to protect at least. And I think we're just difference of opinion on that. No disrespect. And
No, none intended, none taken. Thank you, Secretary. Look forward to helping.
Say your resting.
I had to step out